Face, muscles of the face. Muscles of the face and scalp develop from the second pharyngeal arch and, consequently, receive their motor innervation from the facial nerve, CN7, the nerve of the second pharyngeal arch. The muscles of the face and scalp are derived from the second pharyngeal arch, hyoid arch, mesenchyme that migrates to its final destinatlon. Considering the origin of these muscles, it is not surprising that they receive motor innervation from branches of the facial nerve, CN7. Rather than inserting into bone, these muscles insert into the dermis of the skin, thus their orchestrated contractions convey various shapes to the face that we interpret as emotions. It is important to understand that fascicles of these muscles intermingle with each other, and they tend to act in groups to control the orifices around which they are grouped, such as the orbit, nose, and mouth. It is according to this grouping that they are described. Muscles of the ear and nose, auricular muscles attach to and are capable of moving the external ear but are not often used and thus lose their tone. 3 separate muscles of the nose are capable of flaring the nostrils, depressing the eyebrows, and constricting the nares. The 3 external muscles of the ear are the auricularis anterior, superior, and posterior. Similarly, the 3 muscles of the nose are the procerus, nasalis, and depressor septi. These 2 groups of muscles are fairly inconsequential. Pertinent information concerning them is found in this table. Muscles surrounding the orbit. 3 muscles are concerned with opening and closing the eyelids and forming vertical wrinkles between the eyebrows. The 3 muscles concerned with the orifice of the eye are the orbicularis oculi, corrugator, and levator palpebrae superioris. The last of this group is considered in the chapter 10, Eye and Ear. Orbicularis oculi. The orbicularis oculi muscle is composed of 2 parts, the palpebral portion and the orbital portion. The former originates from the medial palpebral ligament, attached to the medial aspect of the orbit, and inserts into the lateral palpebral raphe, attached to the lateral aspect of the orbit. The orbital portion of the muscle describes an oval around the orbit. The orbicularis oculi is innervated by the temporal and zygomatic branches of the facial nerve and acts to close the eyelid completely. Forceful closure is mediated by the orbital portion, whereas the palpebral portion is responsible for light closure, as in blinking. Corrugators. The corrugator, supercilii, muscle is located deep to the superomedial aspect of the orbicularis oculi, at the medial aspect of the eyebrow. It originates at the medial extent of the superciliary arch and inserts into the skin of the eyebrow. It is innervated by the temporal and zygomatic branches of the facial nerve. The combined actions of the paired muscles approximate the eyebrows, producing frowns. Muscles surrounding the mouth. Muscles functioning around the mouth include those elevating the upper lip as well as dilating the nares, lifting and depressing the corners of the mouth, depressing the lower lip, drawing corners of the mouth laterally, protruding the lower lip, and closing, pursing, and protruding the lips. The muscles of the mouth act to alter the shape of the orifice. Their fibers of insertion intermingle with each other, therefore, they share a commonality of action and almost always act in concert. Orbicularis oris. The orbicularis oris completely encircles the mouth. Its fibers are positioned at various depths and angles in the 2 lips. Fascicles of this muscle, some of which are derived from those of neighboring muscles, especially the buccinators, freely intermingle with fascicles of other muscles acting on the lips, permitting extensive movability. Many of the fibers of the buccinator cross over each other at the angle of the mouth, so the upper fibers proceed to the lower lip and the lower fibers to the upper lip. Hence, the origin of the orbicularis oris is complex and is usually considered to be from the fibers of the surrounding muscles as well as from the alveolar portion of the maxilla, the septum of the nose, and the area lateral to the incisive fossa of the mandible. Insertion is into the skin and into itself, forming an ellipse around the mouth. Buccal branches of the facial nerve innervate this complex muscle, which closes the lips and, during stronger contraction, purses them, as in osculation and whistling. Rhizoreus. The rhizoreus is a small, horizontally placed muscle that originates in the masseteric fascia and inserts in the skin of the corner of the mouth. This is the smiling muscle. It is responsible for drawing the corners of the mouth laterally. The rhizoreus is innervated by buccal and mandibular branches of the facial nerve. Depressors of the lip. The depressor labii inferioris is quadrangular in shape. It originates on the medial extent of the oblique line of the mandible and inserts into the skin of the lower lip. It acts to depress the lower lip. The depressor anguli oris, triangularis, originates on the oblique line of the mandible and inserts into the skin of the corner of the mouth and depresses it, expressing sadness. The mentalis is a small muscle of the chin. Its origin is in the incisive fossa of the mandible, and it inserts into the skin of the chin to wrinkle it and also to protrude the lower lip, as in drinking. The platysma was previously detailed in Chapter 7. All of the muscles of this group, except the platysma, are innervated by the buccal and mandibular branches of the facial nerve. Elevators of the lip. 5 muscles elevate the lip and corner of the mouth. The levator labii superioris nasi is the most medial of these muscles, originating from the frontal process of the maxilla passing inferiorly along the side of the nose. It then splits into a medial and a lateral portion to insert into the wing of the nose and into the upper lip. This muscle functions in dilating the nostril and raising the upper lip. The levator labii superioris originates from the maxilla and zygoma just inferior to the orbit. Its fibers pass across the infraorbital foramen to insert into the upper lip, lateral to and intermingling with the fibers of the levator labii superioris nasi. The levator labii superioris elevates and protrudes the upper lip. The levator anguli oris lies deep to the levator labii superioris. It originates below the infraorbital foramen, from the canine fossa of the maxilla, to insert into the corner of the mouth. This muscle elevates the angle of the mouth and assists in the formation of the nasolabial furrow. The Zigomaticus Minor, a slender muscle arising from the maxillary process of the zygomatic bone, inserts just lateral to the insertion of the levator labii superioris muscle. This muscle elevates the upper lip. It also assists in the formation of the nasolabial furrow. The Zigomaticus major is the lateral-most muscle of this group. It originates on the temporal process of the zygomatic bone and inserts into the corner of the mouth. This muscle elevates the corner of the mouth and pulls it laterally. All of the 5 muscles acting to elevate the lips are innervated by the buccal branches of the facial nerve. Muscle of the cheek. The buccinator, a quadrangular-shaped muscle occupying the space between the mandible and the maxilla, is the primary muscular component of the cheek. It lies deep to the muscles of facial expression and is separated from them by the buccopharyngeal fascia and the buccal fat pad. The parotid duct pierces the substance of this muscle to enter the oral vestibule. The buccinator originates on the maxilla and mandible, specifically on the buccal surfaces of the alveolar processes in the vicinity of the 3 molars, and from the pterygomandibular raphe, a collagenous tendinous inscription attached to the pterygoid hamulus and the mylohyoid line of the mandible. This raphe is interposed between the buccinator and superior pharyngeal constrictor muscles. The buccinator inserts into the fleshy corner of the lip in such a fashion that the upper fascicles and the lower fascicles decussate at the corner of the mouth and insert into the lower and upper lips, respectively, becoming fibers of the orbicularis oris. The highest and lowest fascicles, however, continue without decussation into the upper and lower lips, respectively. The buccinator muscle acts to press the mucosa of the cheek against the teeth, thus aiding in mastication and deglutition. In addition, it assists in distending the oral vestibule and forcefully expelling air, as in blowing dust particles off a surface. The buccal branch of the facial nerve innervates this muscle. Sensory innervation of the face. Sensory innervation to the face is supplied by all 3 divisions of the trigeminal nerve, CNV. Additionally, areas about the mandibular ramus and the ears are served by sensory branches of the cervical plexus. Sensory innervation of the greater part of the face is mediated by branches of the ophthalmic, maxillary, and mandibular divisions of the trigeminal nerve. In addition, the region superficial to the angle of the mandible, the posterior aspect of the inferior portion of the ramus, and most of the ear are supplied by the great auricular and, to a lesser extent, The branches of the trigeminal nerve supplying sensory innervation to the superficial face follow: ophthalmic, lacrimal, supraorbital, supratrochlear, infratrochlear, external nasal. Maxillary, infraorbital, zygomatico-facial, zygomatico-temporal. Mandibular, auriculotemporal, buccal and mental. Ophthalmic division. The ophthalmic division, V1, of the trigeminal nerve enters the face through the orbit as several branches to provide sensation for the upper eyelid and the region superior and lateral to the orbit. Another branch exits the lower rim of the orbit to serve the eyelids and the area about the face and side of the nose. The lacrimal nerve leaves the superolateral aspect of the orbit as the palpebral branch and enters the upper eyelid to distribute to the lateral half of that structure and the conjunctiva of the eye. The frontal nerve bifurcates in the orbit to form the supraorbital and supratrochlear nerves. The supraorbital nerve leaves the orbit via the supraorbital foramen, or notch, after supplying a branch to the frontal sinus. The supratrochlear nerve passes superior to the trochlea and leaves the orbit medial to the supraorbital foramen. These two nerves supply sensation to the upper eyelid, the conjunctiva, and the medial half of the forehead and scalp. The Infratrocalcar Nerve, a branch of the nasociliary nerve, leaves the orbit by passing between the middle palpebral ligament of the eye and trochlea to innervate the medial half of the eyelids, the medial angle of the eye, and the side of the nose. The external nasal nerve, a branch of the anterior ethmoidal branch of the nasociliary nerve, leaves the nasal cavity at the distal end of the nasal bone. This nerve provides sensation to the middle of the bridge and part of the ala of the nose. Maxillary division. The maxillary division, valve of the trigeminal nerve enters the face via the infraorbital foramen, providing sensation to the skin of the lower eyelid, nose, upper lip and mucosa of the labial vestibule. The infraorbital nerve is a continuation of the maxillary division of the trigeminal nerve. After coursing through the floor of the orbit, the infraorbital nerve enters the face via the infraorbital foramen, where it forms a tuft of nerves that may be categorized into three groups: inferior palpebral branches, serving the skin of the lower eyelid and conjunctiva; external nasal branches, providing sensory innervation to the side and mobile septum of the nose; and superior labial branches, supplying the upper lip and mucosa of the superior labial vestibule. The zygomatic branch of the maxillary division of the trigeminal nerve bifurcates to form the zygomatico-temporal and zygomatico-facial nerves. The former enters the superficial face a little superior to the zygomatic arch and supplies sensation to the region of the temple. The latter emerges in the superficial face by way of the zygomatico-facial foramen to serve the skin over the zygomatic bone. Mandibular division. The mandibular division, VT, of the trigeminal nerve provides sensation via several branches to the temporomandibular articulation, the anterior aspect of and about the ear, skin of the temple, skin over the cheek, buccal vestibule, and gingival to the corner of the mouth, chin, lower lip and oral vestibule, and the mandibular teeth and supporting tissues. The auriculotemporal nerve is a branch of the posterior trunk of the mandibular division of the trigeminal nerve. It appears in the superficial face just behind the temporomandibular articulation, where it gives rise to the anterior auricular branches serving the anterolateral surface of the ear, and superficial temporal branches to the region of the temple up to the coronal suture. The buccal nerve lies on the surface of the buccinator muscle as it emerges from beneath the masseter muscle. The buccal nerve provides sensation to the cheek and, on piercing the buccinator muscle, supplies sensation to the mucosa of the buccal vestibule and buccal surfaces of the gingivae as far anteriorly as the corner of the mouth. The mental nerve enters the superficial face via the mental foramen of the mandible to serve the chin, the lower lip, and the surrounding mucosa of the oral vestibule. Motor innervation. The muscles of facial expression are derived embryologically from the second pharyngeal arch, and thus receive motor innervation from the facial nerve, CN7, the nerve of that arch, facial nerve 7. The facial nerve, the nerve of the second pharyngeal arch, leaves the cranial cavity via the internal acoustic meatus and travels in the temporal bone along with the vestibulocochlear nerve. After separating from the vestibulocochlear nerve and giving several branches within the temporal bone, it emerges through the stylomastoid foramen. A posterior auricular branch arises from the trunk, then passes posterior to the ear on its way to innervate the occipitalis and posterior auricular muscles. The main stem of the facial nerve then supplies fibers to the stylohyoid muscle and the posterior belly of the digastric muscle before entering the deep aspect of the parotid gland. Here it subdivides into the temporofacial and cervicofacial divisions, which combine to form a loop within the substance of the parotid gland. It is from this loop that the 5 terminal branches of the parotid plexus arise to supply motor fibers to the muscles of facial expression. Temporal branches, the superior most of these, supply the muscles in the region of the temple and part of the forehead. Zygomatic branches fan out to serve muscles in the area of the prominence of the cheek to the lateral angle of the eye. Buccal branches, the largest of all the branches and serving the greatest area, course across the masseter and buccinator muscles to innervate muscles of the upper lip and nose. Mandibular branches pass deep to the depressor anguli oris and platysma. Although there is no universal agreement, most anatomists believe the buccal branches assist the mandibular branches in supplying the muscles of the lower lip. Cervical branches pass deep to and innervate the platysma muscle. Blood supply of the face. The face is a very vascular region because it receives its blood supply from the external carotid artery and its major branches. Additional blood is received from branches of the internal carotid artery. Because of individual variation, there is disagreement regarding innervation to the muscles of facial expression, especially those surrounding the mouth. In many instances, buccal branches assist mandibular branches in innervating the muscles surrounding the lower lip. Arterial supply of the face. Arterial blood supply to the face is provided by smaller branches of primary branches of the external and internal carotid arteries. Anastomotic networks form over much of the area, ensuring that the face has a very rich blood supply. Vascular supply of the superficial face is derived from branches directly or indirectly arising from the external carotid artery as well as from branches of the ophthalmic artery, a branch of the internal carotid artery. Terminal branches of these vessels form an extensive anastomotic network permeating the superficial aspect of the face. Some of these vessels travel with like-named nerves, and their distribution follows that of their nerve counterparts. Facial artery. The facial artery is a branch of the external carotid artery. Its cervical branches were described earlier. This artery crosses the mandible to enter the face just anterior to the masseter muscle, lying in the groove for the facial artery on the mandible. In the face, the artery travels superficially, just under the cover of the platysma muscle. It passes, via a tortuous path, deep to the Zigomaticus major, risorius, and levator anguli oris muscles to the corner of the mouth. Here, it ascends lateral to the nose to terminate as the angular artery at the medial corner of the eye. Branches of the facial artery in the face are the inferior labial, superior labial, lateral nasal, and angular arteries. Superior and inferior labial arteries arise near the corner of the mouth. The superior labial artery courses between the orbicularis oris and the mucous membrane of the upper lip to serve the upper lip, whereas the inferior labial artery courses deep to the depressor anguli oris to serve the lower lip. The superior labial artery also provides small branches to the wing, ala, and bulb of the nose. The lateral nasal artery arises near the wing of the nose to supply that structure and the bridge of the nose. The angular artery is the terminal continuation of the facial artery, supplying the tissues in the vicinity of the medial corner of the eye. Superficial temporal artery. The superficial temporal artery, one of the terminal branches of the external carotid artery, arises near the level of the earlobe. Facial artery compression. Applying pressure to the facial artery as it passes over the inferior border of the mandible just anterior to the angle will diminish blood flow to that side. However, it must be remembered that because of the many anastomoses on the face, the flow cannot be completely stopped in an area where one of its branches may have been lacerated. At its cranial-most aspect to supply the region superficial to the zygomatic arch as far medially as the lateral corner of the eye as well as the temple and the lateral aspect of the scalp. The transverse facial artery, a branch of the superficial temporal, accompanies and supplies the parotid duct in its path across the masseter muscle. In addition, it sends branches to the parotid gland and other soft tissues in the vicinity. The remainder of the arterial supply of the superficial face is derived from either the maxillary artery, a terminal branch of the external carotid artery, or from the ophthalmic artery, a branch of the internal carotid artery. Branches of the maxillary artery. The maxillary artery, lying deep to the ramus of the mandible in the infratemporal fossa, provides vascularization of the face through some of its branches. Only those serving the superficial face are described here, the other branches are treated in subsequent chapters. Branches of the maxillary artery supplying the superficial face are the infraorbital, buccal, and mental arteries. The infraorbital artery, a branch of the third or pterygopalatine portion of the maxillary artery, passes through the infraorbital fissure to lie in the floor of the orbit. It travels in the infraorbital canal and enters the superficial face via the infraorbital foramen to distribute to the lower eyelid, the upper lip, and the area between these two structures. The buccal artery, a branch of the second or pterygoid portion of the maxillary artery, makes its appearance on the face on the superficial surface of the buccinator muscle to supply it, the connective tissue of the cheek, and the mucosa of the buccal vestibule. The mental artery arises from the inferior alveolar branch of the maxillary artery. The mental artery enters the face via the mental foramen of the mandible to supply the soft tissues of the chin. Moses on the face, the flow cannot be completely stopped in an area where one of its branches may have been lacerated. Branches of the ophthalmic artery. Branches of the ophthalmic artery supplying the face are the zygomaticofacial, supraorbital, supratrochlear, and dorsal nasal arteries. The zygomaticofacial artery is derived from the lacrimal branch of the ophthalmic artery. It enters the face via the zygomaticofacial foramen to supply the region of the face superficial to the zygomatic bone. The supraorbital and supratrochlear arteries both arise in the orbit. The former enters the face via the supraorbital foramen, or notch, and the latter makes its appearance medial to the supraorbital notch. These vessels supply the forehead and the scalp. The dorsal nasal artery, a terminal branch of the ophthalmic artery, leaves the orbit at its medial corner to supply the dorsum of the nose. Venous drainage of the face. The superficial face is drained by veins that parallel like named arteries, eventually draining into the facial vein, a tributary of the internal jugular vein. Other veins of the face join the maxillary vein of the deep face to form the retromandibular vein. Venous drainage of the superficial face is via the supraorbital, posterior auricular, retromandibular, buccal, infraorbital, submental, and superior and inferior labial veins, most of which accompany like named arteries. The superficial temporal vein, draining the superficial face, and the maxillary vein, draining the deep face, join to form the retromandibular vein. One additional collecting vein, the facial vein, empties into the internal jugular vein. Facial vein. The facial vein serves as the principal venous vessel of the superficial face. It begins in the medial corner of the eye as the angular vein and passes inferiorly, following the course of the facial artery deep to the Zigomaticus major and Zigomaticus minor muscles, where it parts company with the artery to empty into the internal jugular vein. The facial vein communicates with the pterygoid plexus of veins as well as with the ophthalmic veins, both of which present possible passageways to the cavernous sinus due to lack of directional valves. Superficial temporal vein. The superficial temporal vein follows the course of the same named artery to drain the scalp, temple, and part of the forehead and ear. One of its tributaries is the transverse facial vein, which follows the path of the transverse facial artery. Thrombophlebitis of the facial vein. The facial vein does not contain valves, thus, blood flow may pass in either direction and into other venous vessels that may be connected to the cavernous sinus located in the dural venous sinus deep within the cranium. These connections include the superior ophthalmic vein, the pterygoid venous plexus, the inferior ophthalmic vein, and or the deep facial vein. Infections in the face, especially in the triangular danger zone of the face, may cause inflammation of the facial vein and development of thrombophlebitis, clot formation, of the facial vein. Pieces of the infected clot may become free to eventually pass into the cavernous sinus, giving rise to thrombophlebitis of the cavernous sinus, a life-threatening situation if left untreated. Danger area of the face, the area bordered by the upper lip, the lateral aspect of the nose, and the lateral corner of the eye superior to the supraorbital ridge represents the danger area of the face. Squeezing pimples and tampering with boils in this region should be avoided because the area may be drained directly or from communications to the ophthalmic vein, which leads directly into the cavernous sinus of the cranial fossa. Infection may enter the cavernous sinus via this route, resulting in thrombosis, cerebral edema, and possibly death. Lacerations and facial incisions. Because the skin of the face does not possess typical deep fascia, lacerations and facial incisions tend to gape open. Therefore, they must be carefully sutured to minimize scarring. Bell palsy. Damage to the facial nerve, or its accidental analgesia during dental procedures, results in paralysis of the muscles of the affected side. Damage may occur during surgical involvement of the parotid gland, infection of the middle ear, knife wounds, or at birth during forceps delivery. Paralysis of the facial muscles results in ptosis of the eye, upper eyelid drooping, depression of the corner of the mouth with accompanying oozing of saliva, speech disorder, especially involving labial sounds, lack of muscle tone, and a sagging, distorted face. Trigeminal neuralgia. Trigeminal neuralgia, tic douloureux, an extremely painful, debilitating condition involving pain fibers of the trigeminal nerve, is caused by an unknown etiology but is often associated with dental carious lesions. The pain is often excruciating and is experienced over the face, teeth, gingivae, nasal and paranasal cavities, as well as the external ear canal. These are the areas served by the maxillary and mandibular divisions, although infrequently the area served by the ophthalmic division of the trigeminal nerve may be affected. Treatment varies from alcohol injection into the trigeminal division affected to sectioning of the trigeminal nerve between the pons and the ganglion.